Welcome! My name is Professor Gábor Holló. I'm an ophthalmologist. Today I'm going to speak about a very important, practically important aspects for those who treat glaucoma patients. Please come with me. Let's start with the high technology, namely OCT angiography and visual field testing. This is a representative case which I'm going to show you, a primary open-angle glaucoma patient with very severe optic nerve head cupping, retinal nerve fiber layer loss, and peripapillary capillary loss at the time of the diagnosis. Even in such cases, and also in much less severe cases, our goal of the treatment is to maintain visual functions, visual field, for the rest of the life of the patients. And this is possible. I'm going to show you how this case behaves over several years of treatment and observation. What you can see here on the progression report, you can see that the visual field remained stable on both eyes. In order to achieve such a success, we have to achieve that the patients remain on their successful topical medication and should not stop it, should not be worried about minimal side effects and self-discontinue medication, but at the same time we must be able to stop medication and intervene when medication-related side effects make it necessary. This is what I'm going to show you now. This is Saturday, therefore we don't have patients in the waiting room. However, just imagine that this is an average working day and we have 5 glaucoma patients waiting for their routine consultation, and they all have some degrees of ocular hyperemia. This is very common among topically treated glaucoma patients. From the far, at first glance, we may think that they have the same ocular hyperemia. However, they may have very different ones which requires very different actions from the medical side. In order to separate the different forms of ocular hyperemia and to organize an appropriate medical action to the appropriate type of hyperemia, we need 2 things. One is an educated knowledge on the physiology, pathophysiology, and background of the different types of ocular hyperemia, and the other is a good slit lamp. So please come with me. This is a typical ophthalmology consultation room with some of the typical devices. Today we need only one device, the good slit lamp, because our topic is to present the 5 clinically important types of ocular hyperemia. The first type of ocular hyperemia I'm going to speak about today is topical allergy, which is typical to topically applied alpha mimetics like brimonidine. The patients usually can't easily open the eye, have some discharge, serious discomfort, and redness. If you look at the slit lamp image, you can see that the follicular hyperemia on the conjunctiva is prominent. In more serious cases, you can even see infiltrates in the cornea. So what to do? In this case and similar cases, we have to completely remove the allergenic medications, and then after 1, 2, or 3 months, at this case 3 months, you can see that the patient's eye are easily opening, they have no redness, the patient is happy, and on the slit lamp image you can see a pale conjunctiva. So when true topical allergy takes place and involves the arterial ocular surface inflammation and dilation, we have to completely remove the allergenic agents. The second type is a bit similar, but a little bit less severe, and that is very frequently seen on patients treated with several preserved topical intraocular pressure lowering medications. This is due to exposure to benzalkonium chloride, BAK. We all know that the effect is total dose dependent. And therefore, as you can see, when you see a patient who has difficulties in opening the eye, the conjunctiva is red, the arteries are dilated, even the lid margin is involved, and we realize that the patient has been using topical medications from several bottles, several instillations per day, which are all preserved, then we have to remove or at least significantly reduce the total amount of BAK from the treatment. So what to do? Just remove the unnecessary medications, use fixed dose combinations, which reduce the total number of daily instillations and the BAK exposure, particularly those ones which are to be given once a day, or alternatively remove all BAK and all preservatives and use completely preservative-free medication. Then this ocular hyperemia type is completely reversible. The third type, which is also very important, but significantly different compared to the previous two ones, are related to topical prostaglandin analog medications. We all know that PGAs reduce intraocular pressure by relaxing the uvascular meshwork in increasing aqueous humor outflow. Because of similar reasons, they also relax the veins on the conjunctival surface. Therefore, their use is typically associated with a kind of venous conjunctival hyperemia. This is not an inflammatory process, no need for treatment, and in most cases this is mild, only a mild cosmetic issues. So what we have to do in general is to inform patients even prior to topical PGA medication is started that a mild hyperemia can be expected, which reduces with time, and it is highest at around the second week of treatment initiation in treatment-naive eyes. This is what you see on the slide. This is a kind of unusually intense conjunctival hyperemia due to PGA analog at 2 weeks since the medication was initiated. This decreases later on in most of the patients. We have to understand that conjunctival venous dilation due to PGA therapy is related to the concentration of the active ingredient in the solution. PGA concentration varies a lot across the different formulations in ophthalmology. The lowest concentration is seen for tafluprost, it is 0.015%, while the highest concentration is seen for certain formulations of bimatoprost, it is 0.03%. When you have a PGA analog which has a high affinity to FP receptors which mediate the PGA-related intraocular pressure reduction, the manufacturer can use low concentrations, just like for the case of tafluprost. Then, the side effects, like the hyperemia of the conjunctiva, is much less, so a switch to such kinds of PGAs is reasonable. The fourth and probably most informative type of hyperemia is related to topically applied rho kinase inhibitors. In Europe, this is natarcodil. As we all know, aqueous humor leads through the trabecular meshwork in the conventional flow system, and in open-angle glaucoma, the trabecular meshwork contractility is increased. Therefore, using a rho kinase inhibitor, we can release the contracting elements in the trabecular meshwork, which improves outflow. However, this is not yet the full story. Aqueous humor leads through the trabecular meshwork and via the Schlems canal to the episcleral veins. And interestingly, rho kinase inhibitors also relax the episcleral veins, making aqueous humor and venous drainage easier and better, and probably this has an important role in the reduction of intraocular pressure achieved with this group of medications. This effect, however, is associated with some episcleral venous dilation, that is episcleral hyperemia and conjunctival hyperemia. This is typically not serious. In real-life studies, it has been shown to be mild, and it occurs in approximately 20% of the patients. Interestingly, patients are much less disturbed by this feature than doctors. So almost 90% of the patients who were switched to or received an add-on metatarsutil medication in a real-life study complained about no complaints, so they were happy with the medication. Doctors may be more anxious about hyperemia than patients. And the conclusion at this point is that when the pressure reduction is sufficient, the patient is happy just because of some venous dilation of episcleral hyperemia. We should not stop an effective urokinase inhibitor medication. As a conclusion, I should like to call your attention to the major contrast between those hyperemias which involve the arterial side of the perfusion on the ocular surface, namely allergic and toxic ocular surface hyperemias. They require intervention, medical intervention, and we have to remove the toxic or allergenic agents and substitute them with well-tolerated medications. On the other hand, those venous dilations which are related to PGAs or urokinase inhibitors require no action in the majority of the cases. Since the patients are free of complaints, this is not disturbing for the patients, the eyes open well, and the patients remain free of subjective complaints. The main goal of treatment is to preserve visual functions for the rest of the life after diagnosing glaucoma. So I should like to thank for your attention, for your willingness to listen to me, and I think that this short review of the medication-induced ocular hyperemias will support your treatment decisions in real-life practice and serve the benefit of the patients. Finally, if you are in Budapest, since our center is in the heart of Buda, in the medieval Budapest castle area, which is a part of World Heritage, please have a look and enjoy the site.